I can't see anybody's face here.
I can see that situation at this point of time in the world. Unfortunately, the enemy which we can't see, we are all fighting from the house. So we know that all pediatric cardiologists are academically very well, and they are very happy to share their knowledge with other colleagues. So sitting idly at home and not doing either.
So okay. Can you see my screen as a full screen, or is it a presenter window?
Yes, sir. Full screen. We can.
Sir, it's a presenter window.
Yes, sir.
Okay.
Presenter window.
So I just give me a second. I'll just show a full screen as usual.
Play from start. Yeah.
Yeah. So is this okay now?
Yeah, perfect, sir.
Okay. I have turned off my video for optimal. I'm turning it on.
You can
just
switch it on.
briefly. Yeah, I've turned it on right now. Okay, thanks, Satya. Thank you, Nageshwar, and thank you, Anil Singhi, for actually facilitating, and thanks everyone for joining in with such enthusiasm. This is, yes, these are difficult times, but every challenge is an opportunity, and we will try and see if we can pull off this experiment that we are trying to do. We are trying to do this experiment on learning and from each other virtually at a distance. And if this succeeds, we have plans of doing this on a much larger scale, and through even for situations where we need to interact with each other, like planning studies and in planning registries, etc., etc. So I'm going to talk to you about something which is very basic, and I know that there are a number of people in this group who do not probably need this talk in terms of what one needs to do to plan a procedure. But to the youngsters, to the beginners, to the fellows in training, this talk is useful. And to the others who are not fellows in training, I would welcome your criticisms and inputs on those aspects that I have missed. Maybe that can be done towards the end of this talk. So I'm going to start with this. It's very important to identify your role model in anything you do in life. For cardiac catheterization, Stan Perry was my role model. I trained under this man in Boston in 94 to 96. He embodied every aspect. I think he came closest to the most perfect catheterizer I have ever known in terms of understanding skills, reaction times, etc., etc., etc. He doesn't share his photograph, and you won't find his photograph on the internet. And he did this as a personal favor, just because we had this wonderful close relationship. Wasn't an easy relationship, but I learned everything from him. So much of what I say has a lot to do with what I have imbibed from my teachers, and Stan, without doubt, taught me how to catheterize better, more than anybody else. So the questions that I would like to ask is, why plan? When should we plan? What should we plan, and how should we plan? We always start with the why. I think it's essential that you have to be convinced about the why. And if you are convinced, I think each of us will figure out the rest of the elements in this process. But the basic issue with why we don't, do some things is because we are not convinced. As adults, we don't need to be taught. And so actually the first few slides that I'm going to show you is more important than anything else. I have seen a number of ways in which cardiac catheterizations happen. I've visited labs where it's seemingly chaotic, where there is very little planning, very little discussion prior to the procedure, and everything happens on the fly. Now that is complete antithesis to how I have been trained and how I think cardiac catheterization should be done. So I am convinced that we have to plan to the smallest detail. And the reasons I have to give you are, it ensures safety, it ensures success, it makes you efficient, and it makes you economical. You don't waste time or resources. So if you have planned to the smallest detail, you achieve all these four far more effectively than you just go into the lab without a plan. And that still happens in many labs. People walk in and everything is then on the fly. Now that's something which really is, it works in some ways, but it certainly, if you do a certain number of cats, then things will go wrong in a predictable way. And I'll tell you why that happens. The reason why people still don't plan is because they've seen situations where you find people succeeding and they're seemingly improvising all the time. But to be honest, everybody plans at some stage. A good interventionist is somebody who balances seemingly opposite attributes. To be courageous and do something unknown versus to be cautious and try and make sure that you have every
the more the procedure gets prolonged, the more the chance, especially in neonates, newborns, and infants, is the long time of the procedure which predisposes to infection. The shorter the procedure, the less chances that any newborn or an infant is likely to develop infection. So you keep on attempting, keep on trying to get a vascular act, which you have mentioned here, which you have spoken about. And I think it's very important to do that in each and every case. Thank you for that talk.
Bharat sir, can you give?
Just a couple of comments, KK. I think it was really a good way of starting this program, because without immaculate planning, I think the chances of you going wrong are pretty high. And it is especially true when you are in an academic environment where you need to train the juniors. I think having a protocol in place and following that protocol to the last dot is extremely important. Many times we let our guards down, thinking that now we have done so many cases. I think the important thing is that you must treat every case as if it is your first case. Then you will stick to the protocol to the last dot. The second thing is, I think one of the most important things is audit. I think it is very important, because just saying that I have done 500 cases or 1,000 cases without actually auditing your results, to my mind, is like doing one case 1,000 times. Because if you have not audited, if you don't know where you have gone wrong, there are chances that you will keep on making the same mistake over and over again. And third thing is a planning of the hardware. I think unlike an adult program, I think many of the hardwares are not easily available when it comes to pediatric interventions. And I've heard this many times, even in meetings, people saying that I did this and I did not do this because I did not have this. I think that is not an excuse which is acceptable. You can't take off, go midair and say that I left something on the ground. You have to be sure that you have all the hardware available when you are venturing onto interventions in pediatrics. So these are a couple of points that came to my mind. Otherwise, I think it was an excellent talk, and it was a good revision even for us to go through all this checklist and to know how you can be successful and how you can have how you can minimize complications. Thank you, KK.
So I have a lot of questions in the chat box. Should we go through a few of them, Nageshwar?
Yeah, I think ETCO2 is interesting. You can answer whatever you feel.
Yeah, you do the ETCO2, then I'll go through the rest. I think that's something.
You speak that you give answer from.
So the ETCO2 is something that anesthetists use, and it's very valuable, particularly just to know, to monitor your patient's ventilatory status. But sometimes during situations like when you have an acute reduction in pulmonary blood flow, I think there ETCO2 becomes very, very valuable. I haven't personally found it, to be very honest, extremely useful, except in very rare circumstances. So again, I leave it to the anesthetist really to guide us with what they see.
No, especially when you are doing oxygen study or Down syndrome patients, or you feel hyperventilation.
Yes.
In those individuals, it is going to be useful.
And you should corroborate it with the blood gas all the time. So it's very important to actually check your blood gas.
Would you like to answer the ACT? Somebody is asking.
ACT, what should we target ACT for? I think ACT is critical for stent, PDA stenting that we have. And we essentially target ACTs above 200 minimum to ensure that we have our heparin acting on board. 180 to 200 is something people state, and that's what I choose. And do you have any other thresholds, Nageswar and others?
Yeah, I think 180 threshold. We also do frequent ACT monitoring when we put large sheets into the artery, for example, coarctation, stenting, and if it gets prolonged, we make sure that we do the ACT monitoring also before removing the large sheet. Of course, we don't use the perclose, and also we make sure that the ACT is within the range where it can be safely removed. Otherwise, we would remove the large sheath and substitute a smaller sheath till the ACT returns to acceptable limits. So that's one area where we...
Sir, thank you, sir. Please go ahead.
Thanks, Nageswar, for this kind introduction. What I'm going to do over next 20 minutes is talk to you on counseling a family after a complication. So let me start with this preamble. None of us are going to live long enough to commit all the complications ourselves, and leave alone finding solutions to each of these complications. As a matter of fact, I don't think there is a need for each one of us to reinvent the wheel. And that is the reason why we must keep sharing the lessons that we have learned through each of these complications. Many a times we tend to share our successes, but I think if not equally, even more important, we share our failures so that if somebody else gets into the same problem, we entire strategy and can easily depend on the strategy that you have shared. Oh, you can't hear me?
Sir, we can hear you.
We can hear you, sir.
Okay, sorry. Can you hear me now?
Yes, sir. Please continue.
Okay, thanks. So what I'm going to do is just share some random thoughts on complications, not necessarily only related to counseling, although counseling will be the important aspect of this talk, but to take you through various thoughts that came to my mind dealing with these complications for over the last 3 decades. And the emphasis of this presentation is that it is more relevant to the developing world in many ways. And maybe some of the things are a little superfluous in developed countries. Now, what are the lessons that we have learned from our experience? The first and foremost is that the complications don't knock at our door before coming. They come from nowhere as a bolt from the blue. Yogi Berra, who used to train the New York baseball team, used to say, "It ain't over till it is over." And this is a very common saying in sports. Like in cricket, you always say, "It is not over till the last ball is being bowled." I think in pediatric interventions, we can go a step ahead and say that it ain't over even after it is over, because you can have complications even after the procedure is over. Maybe in terms of hours, maybe in terms of days, and sometimes maybe in terms of years. So I think 2 qualities that you must develop as an interventionist is an alertness to recognize and preparedness to deal with complications. These are extremely important qualities, and I think they will come handy when you get into a problem. Another important aspect is communicating with the patient and family, especially during difficult times. So when you get into a complication, and I think that is an art. Unfortunately, it is neither a part of our curriculum nor a part of our evaluation. Neither in our MD or DM or DNB or FNB examination, we are evaluated for our communication skills. So we hardly learn anything in terms of communications excepting from our seniors. And it comes to us only on the job. So till such time you are in practice, you will never learn the art of communicating with patients and families. I believe the earlier you learn this art, better it is, because most of the problems, whether they are medical, legal, ethical, all those things, I think arise due to improper communication or many times due to lack of it. I think it's very important that you communicate.
Please go ahead, sir.
In the developing world, apart from playing the role of a physician, you are expected to play God. So you decide whether to intervene. For example, there are many centers where hypoplastic left heart will never be intervened in our country. How to intervene? There are many times that for the economic reason, you will ask a patient to go for a surgical intervention rather than going for a non-surgical or an interventional procedure. And many of the mild pulmonary artery stenosis, mild coarctations, which may be treated in the developed countries, you may probably try and evaluate them clinically over a period of time before you take a call on intervention. So I think because family says that, sir, aap jo bolenge wo hum karenge, whatever you say we will do, I think we tend to believe that we are gods. And then while doing an intervention, we say, oh, this is 100%, that we can do this without problem. I think it is important to remember that we are not gods and that we are amenable to failures, to complications. So remain grounded is one of the important messages that I would like to give you. Now, in order to deal with complications, I think, and to prevent them, I think what KK very rightly said, that you must plan your work and work to your plan. If plan A doesn't work, you must have a fallback plan, but then you must always work to your plan. Put systems in place, and that is very important. It may take time, maybe a few days, a few months after you start your program, but putting systems in place is extremely essential because they will give you long-term dividends. Have checklists for every procedure and do not take anything for granted. Learn to expect the unexpected and prepare yourself for surprises and complications at all times. Because as I said, complication will never come with a knock. It will come from nowhere as a bolt from the blue. It is very, very important that you keep yourself prepared and never let your guard down. I think this is a very important aspect. No matter how accomplished you are, no matter which part of the world you are in, I think complications is a part and parcel of our job as an interventionist. I always say that there are three types of interventionists who have zero complications. They either don't work, or they lie, or they are God unto themselves. If you are a human being and if you are working and if you are honest, believe me that you will get into complication sometime or the other. If you cannot deal with complications emotionally, I think the best thing for you is to quit this particular interventional cardiology program, because then you can do something else. If you are doing interventions, I think you will deal with complications all the time. It is important to understand that complications is nothing but a human error. Many times we tend to blame the patient, we tend to blame the defect, we tend to blame the device, tend to blame the stent. But I think more often than not, it is the human error, and most of the times is the operator-related error which results into complications. So one thing is that learn that learn one basic principle, that there is nothing like a slam dunk in interventions. You cannot say, oh, ye to 3 millimeter duct hai, 5 minute ka kaam hai. You may never know when you can get into problem. And that is why don't underestimate any intervention. Do every step as if you are doing it for the first time. Never let your guard down, and do not flout the basic principles of interventions. All these things I'm trying to tell you in order to avoid complications, so that counseling the families and things like that will never arise. Like, for example, pushing against resistance. I think you should never do it. You should never put in a wire without aspirating the catheter. These are basic principles. Once you have removed the catheter, always flush the side arm of the sheath. Without that, don't put another catheter, because you can take the thrombus into circulation, and which have had disastrous consequences. So these are some of the basic principles which you should not flout. Now let me talk about counseling. You get into problems in the counseling process after you get into a complication, because many times you haven't done your pre-procedural counseling well. I think it is very important that you do a good pre-procedural counseling. Many times I have seen that this is left to the registrars and the fellows, but at least in my practice, I always do pre-procedural counseling myself. Once in the clinic and once on the morning of the procedure. It may take you 5 to 10 minutes, but it is better to meet the family on the day of the procedure. Again, reiterate the salient features of the procedure. Remind the family about the finite complications. Sometimes the families like to hear only good things. They don't like to hear the bad things. So they may tend to forget that you have told them about these complications. So it's a good idea to ask them, what did they understand after you have counseled? Ask them some leading questions to confirm what they have understood. So once you do that, the chances of you getting, if the complications were to occur, is less likely. And that is why I say that it is important that you also do one pre-procedural counseling on the morning of the procedure. Now, what are the basic principles that I tend to follow? One is be truthful about the indications, safety, and efficacy, and tell the patient and the family everything that you know. Don't try to sell a procedure. Ye kiya to sab theek ho jayega. I don't think that is a correct way to approach, because as you know, most of the congenital heart diseases, once a congenital heart disease, always a congenital heart disease. So, for example, if you have a patient with ASD closure, if you say that patient develops some atrial arrhythmia, thromboembolic complications, so tell them that despite closure, these are some of the limitations. Also, never scare them into doing a procedure. Never tell them, ye nahi karega to marega. I think this is a wrong way of counseling the families. Never scare them. I think be matter-of-factly, but at the same time, don't be indifferent, because as patients and the family of a patient, I think they need some amount of empathy from you as a consultant. So I think these are some of the important principles of counseling before the procedure. As far as the complications are concerned, I think I have broadly classified them into 3. Minor complications which can be sorted out in the cath lab, like bleeding or arrhythmia or a small hematoma or a stent migration, or sometimes even device migration if you are able to retrieve it. There are intermediate type of complications where a patient may need a transfer to the OR or to the CCU following the procedure. Like, for example, if there is a device embolization, which requires a patient to be transferred to the OR because you are not able to retrieve it. Or if there is a thromboembolism with a stroke, or if there is a cardiac tamponade, which you are not able to control in the cath lab. And of course, then there are major complications, which may either require a CPR or which may be fatal. So this is an example of what I would consider as a relatively minor case of coarctation. We try to stent this coarctation probably undersized, and because of the pulsatility of the aorta due to associated mild to moderate aortic regurgitation, we ended up with a stent coming into the abdominal aorta. But then we stabilized the stent in the abdominal aorta and went ahead and stented the coarctation. So this I would consider as something as a minor complication. This is an example of a 34 millimeter device closing a 30 millimeter ASD. You can see that the device looks pretty good. But at the time of extubation, due to retching and vomiting sensation, the patient managed to get the device into the right ventricle. I think this complication also, if you are able to get the device into the sheath, as we did in this case, probably can be considered as a minor complication. And you can see that we have got the device out and then went ahead and closed the defect with the 36 millimeter device. But this may not be the case every time, as the so-called minor complication will become relatively major if you have to take this patient to the operating room, as was the case in this patient, where we embolized a 38 millimeter device, could not remove it in the cath lab, and had to be removed in the operating room with closure of the ASD. And now I will show you one of the complications which I consider as a major complication. So this is a mid-muscular VSD in a 3.5-year-old child. This is done many, many years back, maybe 8 or 9 years back, or even maybe. So we started closing this device. We made an arteriovenous loop, as is seen here, and then got our delivery sheath. At that time, those delivery sheaths were far more thrombogenic. And that is why, probably they were not like the sheaths that we have for delivering the devices now. So we got the sheath into the ascending aorta. And this is the muscular VSD device, which is coming from the sheath. The moment we got the LV disc into the left ventricle, you see what happens. The patient actually crashed on table. And you can see that the pressure has dropped to nearly 15 millimeters of mercury. We had the echo machine. We looked at the aortic valve, looked at the mitral valve, looked at the pericardium for any effusion. But if you see very closely, there are some ST elevations in lead 1. So we thought that probably we might have had some problem with the coronary. We had to start the CPR here, and my colleague, Dr. Robin Pinto, he's an adult cardiologist as well. So he could, in the meantime, get the catheter into the left coronary artery. And you can see that there is a huge saddle-shaped thrombus, both into the LAD and into the left circumflex. So what we did is that we changed the catheter to a guide catheter, and we continued with our CPR. And you can see that with CPR, we are able to generate a pressure of nearly 60 millimeters, which was probably adequate for a child under anesthesia. And then we wired the LAD. And if you see closely, you can see one point going in and out, what we call as dottering of the artery. Just taking the balloon in and out to break the thrombus. And we did not only in LAD, but also in the circumflex. And you can see that the flow then comes back. And then over a period of time, we were able to recanalize both the LAD and the circumflex. And then we were able to get the coronaries clean. The pressure, of course, with inotropes went pretty high. We let the pressure come down, and then we went ahead and closed the VSD in the same sitting with a reasonably good result. So this is what I would consider as a major complication. And as KK said, that had we probably done the ACT, or had we been more particular about flushing of the sheaths, probably we could have avoided this. We had good heparin on the board, and we were sure that we had flushed the sheath adequately. But then these are some of the things which are unexpected and really come as a surprise. and this is how the patient went out of the lab. Now, when you have a complication, again, it's better to counsel the family yourself and don't let your colleagues or let your registrars counsel. Many times I have seen doctors counseling families in the corridor. I think that is not a great practice. Always have a counseling room next to the cath lab or next to the CCU or wherever. You make the family comfortable when you talk to them, offer them a seat, and then you start talking to them or counseling them. Let the family know everything about the complication. Don't try to hide anything. Explain to them the sequence of events as they occurred. And also tell them what are the steps that you have taken and what are the steps that you are likely to take. Let them know your plan. What is most important is clarity of thought and clarity of action when you are dealing with complications. If your thoughts are clouded, believe me, your actions will not be really as good as you want them to be. So you should have a clarity of thought. And when you are dealing or when you are trying to tell the family, I think you must tell them with clear mind. This is one of the most important aspects of counseling. Never, never, never blame your colleague for a complication. Maybe a medical colleague or a paramedic. You must always lead from the front because you take the bouquets, you should be ready to take the brickbats. Never say that you did like this or you gave me this device. Absolutely not acceptable. And certainly not when you are counseling the families. Never be aggressive during counseling. Family is under stress. Family is going to get aggressive. Sometimes the families can be abusive. Although in our experience, it is very, very rare that I have seen an abusive family, but not impossible in the current. Do not try to match their aggression with your aggression. And certainly, can never afford to be abusive. So neither get aggressive nor be abusive. These are just not acceptable as a part of your training, as a part of your profession, because you are a physician. Now, what is your job? Your job is to save the child and or to reduce morbidity if it is not life-threatening. Work towards that goal. When you are in a complication, it is not the time to think, what will happen to me? Will there be a medico-legal consequence? Will I be sued? What will happen to my practice? What will happen to my attachment? All these things will cloud your thinking. And as I said, if it clouds your thinking, it will cloud your actions. So always be positive. Do everything possible under the circumstances. And not only that you should do it, but it should be seen that everything was done for that child. Don't think about the cost, how much that snare will cost, how much that bioptome will cost. Remember one thing, that human life is priceless. Even if you have to pay from your own pocket for that case, it doesn't matter, but do everything. Otherwise, the guilt will haunt you for the rest of your life. These are some of the important things. When you get into a complication, keep the family in the loop all the time. It is not possible for you to talk to them every time, but tell them that from now onwards, this colleague of mine or this nurse will come and talk to you till such time I complete the procedure, because ultimately you have to take care of the child as well. Do not abandon the patient. It is very important. When there is a complication, many times you say that, okay, you look after this, I have to do something in the outpatient, I have to look in the ICU. Cancel your schedule till such time either the patient is settled or you hand over the patient to a surgeon or an intensivist in the ICU, or the patient succumbs if the unfortunate circumstances take their toll on patient's life. Regarding death, it is my practice to break the news of the death myself. I have never let my juniors or my colleagues break the news of death. And you have to be empathetic and you have to be willing to take everything that the family will tell you. There are patients' families who can tell you that you have killed my child. And you should be mentally prepared for this if that unfortunate event were to occur. I think you must listen to the family. Don't try to interrupt every now and then. Oh, maine aisa kiya. No, I did. First, listen to the family. If they have any questions, answer all their questions. Never dodge any questions. And I think you must answer them very frankly. Tell them whatever you know upfront. Remember one thing, discussing complications in a meeting is different because there you have a scope for conjectures. When you're talking to the family, I think there is no room for conjectures. You say that this is what you know, you tell them that this is what you don't know. Honesty, in my opinion, is the bottom line and is the best policy while dealing with patients and their families in distress. Our job as interventionists is like that of a wicketkeeper in cricket. You may collect 1,000 balls behind the wickets, but you will never be pardoned if you let go one snake. You may close thousands of ASDs, but every embolization, every erosion, you will be held responsible. In cricket, there is a second chance. If you score a 0 in the first innings, you can manage to score a century in the second. Remember, in interventions, there is only one chance. There is no second chance in the same patient. You may have a second chance in a different patient, but not in the same patient. And lastly, before I conclude, as I grade, I have realized one thing. It is not your ability to intervene successfully, but your way to deal with complications. And I think that is what separates boys from men in this exciting field of structural and congenital interventions. Thanks for your patient hearing, ladies and gentlemen.
It's really wonderful, sir. A lot of things, counseling, self-counseling, we may overcome these issues. Really wonderful. Thank you very much, sir. Maybe other people, KK sir and Radha sir, can give a couple of comments or any short questions you can answer, then we can go on to the next.
Nageshwar, this was an excellent talk. Bharat, superb, because I think we've gone through these. As you said, there is probably no one who spent as many years. If you spend enough years, you will go through a complication. It is inevitable and you have to then handle. And I think the most difficult aspect of the complication is talking to the family. Without question, that is the most, the aspect that breaks your heart, that makes you nervous, that worries you most. So handling that is far more challenging than handling the complication itself sometimes.
I couldn't agree with you more on that issue, KK. And one more thing I wanted to tell you, I left academics pretty early in my career, but both you and Radha are in academic institutions for a very long time. And I'm sure that people who trained with you probably were also trained in the skills of communication when it comes to counseling families. Because I must say that when I trained myself at KEM, this was not a part of my curriculum. And I never actually learned the art of communication unless till such time I went abroad. I saw many centers, many institutions, and many consultants, and the way they spoke with the patients and the families. I would like to know from both of you, since you have spent so many years, that do you really take special care of training your fellows in the art of counseling?
We emphasize on this considerably. I don't know if we formally take classes, but it's a good idea now that you've done this talk of yours. And it's a fantastic idea to have included your talk in this particular curriculum. We haven't actually formally had classes on how to communicate. I think that's a big deficiency of medical system in this part of the world in general. We have not been taught formally how to communicate vis-a-vis, let's say, UK or anywhere else where this is incredibly important. I think this has to be now formally taught to everyone. Important. We set some examples for our fellows to follow. They work with talking to families. Sometimes we do a very good job. Sometimes we don't do a great job. They have enough feedback from families and their reactions, so they know when we've done a good job. But I agree with you. I think we have to be more conscious to think about this. We haven't given it enough a thought. and be a very high priority on our curriculums. What it does.
Sir, can you please unmute Radha's microphone?
No, we can't hear Radha. Yeah.
That was a wonderful talk. Thank you. We also face this problem sometimes about counseling. So there are two things that we do, especially when it comes to very sick babies. We call our own colleagues. For example, I would call Sushil and say, let's talk together with the patient, because most of the time both of us are involved. The other thing that is most stressful is when the whole thing gets prolonged. A patient staying in the ICU for 2-3 weeks after a procedure as a part of the patient. The patients are sick, but the procedure has made them sicker. So that's the time when we involve the hospital administration also. We have a joint meeting with the medical superintendent or anybody who is in the responsible post. We sit together and then talk about the problems, because one of the most important problems, they ask you, how long is this going to go on? How much cost it will occur? Will you give me a concession? So we make it a point to sit with the hospital administration and talk to them as a group. And all these things are noted basically for medical legal purposes. So that is how we do at our place. So we feel very comfortable when two of us are together talking to the patient, and instead of only one talking and later the patient's relative saying that, look, you didn't tell me all these things. So, just to protect ourselves, and at the same time, two consultants talking to the patient makes it much more helpful.
Radha, only one comment I wanted to make. When the child is sick and you are counseling the family, that I think is an easier part of counseling, because the child is sick and sometimes, these adverse outcomes are expected. The problem happens when you have a child who is asymptomatic, who has walked into the hospital, for example, ASD.
Sure.
And, if you were to have a complication which is life-threatening, believe me, the patients will be really, they will be at your throat because they have got the child, and that is why I feel that every patient should be counseled in the same fashion with a particular protocol, that these are the morbidities and that there is a finite chance of mortality, although it is an accident which you cannot foresee. That should be emphasized on the day of the procedure to every family.
Thank you, sir. We'll conclude this talk, and then Dr. Radhakrishnan to give talk on anatomy of intraatrial septum and interventricular septum with reference to the intervention. I know.
Nice to see you there. I hope all of you are safe. I spoke to Nagesh day before yesterday as to what he wants from me, because this is an interventional meeting. Even I'm not sure whether this is an appropriate forum in this particular talk, but I decided to concentrate on basically the anatomy of the atrial and ventricular septum, and also the echo pictures of how we classify atrial septal defect and basic ventricular septal defect. It may not be directly related to the interventional aspect of this whole thing, but you have to bear with me. Now, this is something which we are always very scared of, that is the embryology. But as far as atrial septal defect is concerned, you have to remember a very important thing, that it starts with the ostium primum. That is, the ostium primum, the septum primum grows down in the 4th week of the embryological growth. And then subsequently it gets replaced by what is known as the septum secundum, which is actually, if you look at the right side bottom screen, is actually the ingrowth of the atrial wall. This is not a part of the septum. So if you actually look at the anatomy of the atrial septum, the only true fossa ovalis is that portion of the atrial septum which is a part of the septum primum. The rest of it, they are all actually the protrusions of the muscular portions of the atria, which actually start superiorly from here, then goes down and then extends anteriorly towards the aorta and inferiorly towards the inferior vena cava. So the true portion of the atrial septum, as we see, is not the whole septum, but what was originally the septum primum. That is what is known as the fossa ovalis. So this anterior rim, if you see, continues into the aorta here, and then inferiorly that whole muscular portion of the septum then continues towards the IVC. So when we start assessing an atrial septal defect, it is always nice to start with the clinical X-ray, ECG, and also the oxygen saturation. Because the evaluation has to be complete. It is only then that we should move on, which for atrial septal defect includes transthoracic echo, which is usually a 3D TE echo, and of course the ICE, which is used for intervention. I will be restricting my talk only to the transthoracic echo because tomorrow Saurabh is going to speak about transesophageal echo evaluation, etc. Very rarely do we have to use MRI or CT, although there are studies which shows that there is a good correlation of MRI with echocardiography as far as rims, size, and all is concerned. And of course, you have to be prepared for a cardiac cath. Even if you want to intervene or no intervention by device closures, you have to be mentally prepared for a cardiac catheterization study. So let's look at the anatomy of the type of interatrial communication. This is a cartoon where the anterior wall of the right atrium has been removed. And what you're seeing is the interatrial septum and the various places. Most of you, of course, would be familiar with this, but for a beginner, it might give you some information as to how the atrial communication exists. Actually, the true fossa ovalis AST is actually in the center, and the rest of them, they are all away from what is the embryological atrial septum, which is only the central portion of the atrial septal communication. Echo assessment is the cornerstone for imaging. In many cases, this may be the only investigation necessary for the treatment in terms of anatomy, size, rims, hemodynamics, ventricular function. This echo may be the only thing necessary. Correct assessment of rims is usually necessary when you're contemplating of a device. But when you know, if you look at an echo and see, oh, this is too huge for a device closure, then generally we are not very bothered about trying to measure the rims, etc. And we just go ahead and mention the size and then go on to the hemodynamics, etc., before we contemplate referring to the surgeon and, if necessary, do a cardiac cath. I believe this is very important. Current nomenclature of the rims is absolutely important. It is important to define the rims according to the adjacent structures like SVC, IVC, atrial, AV septal, retroaortic rim. Unfortunately, even in today's echo reports, we frequently ignore these for vague terminologies like superior defect, inferior defect, anterior defect. We still see reports which do not follow the strict criteria of defining the rims, because when they come to you with these reports, they expect you to give you an answer as to whether you would be able to do it by device or whether the patient has to go for surgery. And many times we have to tell them, look, this is not enough for me to conclude. So that's very embarrassing. So one should try to avoid it, try to follow these rules, and try to define the rims according to the structure that you see. We made a plea for this right way back in the 90s, but it's still being ignored. As far as the AST is concerned, always start with the subxiphoid windows and use the two which complementary views, the sagittal and coronal. Even when you're doing these subxiphoid windows, you have to make dynamic changes in the scan plane to look at the various parts of the septum. Because if you look at these reports, especially echo reports, one actually tends to measure the smallest part of the atrial septal defect. Unfortunately, that is not enough. You have to measure the largest portion of the atrial septal defect in order to say whether it is suitable for a device And this usually happens when you have these fixed sagittal and coronal views, and you don't change the dynamic nature of the scan plane and then miss out on the largest size of the defect and then tell them, oh, this is suitable for a device closure. Also, these views, it will help us to rule outside defects like IVC or SVC. But that if the sub-xiphoid windows are not good, then TE is the only option, especially when you're trying to plan a device closure. Also, it is a very important window if one is considering a device closure without resorting to general anesthesia and TE. So if your sub-xiphoid windows are not good for evaluating an atrial septal defect, then it is quickly better to move on to the transesophageal VCOs, define the rims properly, define the size properly, and then you may or may not decide to do the device under GA or TE guidance. That's up to the operator, although we believe that almost all the atrial septal defect, even if it looks very good, should be done under general anesthesia and TE guidance. This is especially true for the beginner. As your experience increases, you can choose which ASD to do without general anesthesia or without TE. But as a beginner, I think this is a very, very important thing to do. There is always this excuse, I don't have an anesthetist with us, I don't have a TE. You should try to take shortcuts. Am I okay? Because it's coming as muted. My voice is muted. Bharat, can you?
No, sir, we can hear you.
Okay.
Just a second, sir.
Sir, please go ahead.
Thank you.
Yeah. And somebody is trying to draw something on the screen.
Yes.
Please don't draw anything on the screen.
So here we have the two complementary coronal view, which looks at the atrial rim, at the AV septal rim, and then we make a measurement here. We then move on to the complementary views, which looks at the SVC rim, the IVC rims, and then we make the measurement. Because remember that these are fixed views. As I said, you have to scan the atrial septum even in these views in a dynamic way, going superiorly, inferiorly. So this should not be forgotten. Otherwise, you will miss the largest size of the defect and tend to concentrate only on the views which looks very good. This is the third view, which is the epic, which measures the IVC rim. It also measures the AV septal rim. And finally, the fourth view is the parasternal short axis view, which looks at the posterior rim, which is actually the pulmonary rim and the rectal. So these are useful, which makes us decide whether we are able to do it with a device or not. So this is as far as the fossa oval is concerned. If any of these images are not good, then I think we should not hesitate to do a TE in order to get a complete information. The other types of defects, all other atrial communication lie outside the confines of the true atrial septal defect, embryologically speaking. So there is a plea not to call them as atrial septal defect, but just to call them defects, although intuitively, because of many years of habit, we still call a sinus venosus AST, an atrioventricular septal AST, coronary sinus AST, etc. But there is a strong plea as to not to call it correctly in terms of embryological defect. There was a time when all these were never considered for a device has coming and which has been going on for quite some time, for the past 2 or 3 years, when people have started closing sinus venosus defects. So it is one day we might start and close the IVC type of sinus venosus defect. We never know. So it is very important to understand the anatomy. So I'll be talking briefly about the sinus venosus defects and the atrioventricular septal defect. SVC type of sinus venosus defect, basically they are defined as an overriding of the superior caval vein with a biatrial communication. So perforce, it's a very superior defect. What is always associated is a PAPVC of the right upper pulmonary vein. It is a part and parcel of the defect. Many people don't understand it because they come and ask you, what about the pulmonary veins? Is that also draining anomalously? And these are from people who probably don't understand the anatomy very well. So PAPVC of right upper pulmonary vein is always a part of a superior sinus venosus defect. If a fossa ovalis ASD is also present with it, remember that the criteria for diagnosis is that you have to have a tissue which separates the two. Otherwise, it just becomes a large fossa ovalis ASD which is extended superiorly. So we have to differentiate these two. For a pure SVC type of defect, you have to have a rim which is separating it from the fossa ovalis. These things are very well demonstrated by using the subxiphoid sagittal views. It is completely missed in the four-chamber views. So if a subxiphoid view is poor, then you should always use the TE if a suspicion of ASD is strong. Let's look at this image. This is an apical four-chamber view. One could never imagine this patient would have an atrial septal defect. And this has happened. It still happens. What you notice is, of course, the right atrium is enlarged. All you need to do is, if you can get a good subxiphoid image in this particular picture, you know that you're dealing with this SVC type of sinus venosus defect. Many times what happens is the defect is extremely anterior and superior. And you can actually miss it even during a good subxiphoid window. And the example of this is the one which I pointed out in the bottom picture. It has been also known that sometimes even the surgeons can miss it if they are a bit casual about it. I have had instances, twice I have had instances where a patient chest was opened up with a diagnosis of sinus venosus defect, and the chest was closed and said there was no defect because it was lying so superiorly and anteriorly. But in 99% of cases, the subxiphoid window is good enough to diagnose a superior type of sinus venosus defect. IVC type of sinus venosus defect are much more difficult to diagnose. It is easy to diagnose the defect, but it is difficult to label it as an IVC type of sinus venosus defect. It is very common, if you see the reports coming in, to label it as a fossa ovalis defect. The features like the SVC type of defect is that here it is an inferior and posterior defect. You have the overriding of the IVC instead of the SVC, but it is not easily appreciated. Again, it has to have an intact fossa ovalis. If a fossa ovalis ASD is also present, then there has to be tissue which separates it, very similar to that of the SVC type of defect. And PAPVC of the right lower pulmonary vein is optional, and many times it is difficult to demonstrate. So this is the example of a dynamic scanning, which is very important. It's the same patient. You see in a superior scan where the SVC is entering the right atrium, it looks as if the atrial septum is intact. But the moment you sweep it posteriorly, you see this large defect which is appearing, which is towards the IVC, not yet fully clarified, but then you could have completely missed it if you don't do a dynamic scanning of the atrial septum. The left-hand screen looks as if it is an intact septum, but the right-hand screen clearly shows that there is a large defect which is inferior and posterior. Another example. This is the same patient where you see that the fossa ovalis is intact. Intuitively, you would say that, oh, look, this is an intact atrial septum. Unless you do a posterior scan, you see this huge defect appears and you see that the IVC is overriding this defect. So that's the importance of a dynamic scan in order not to miss these difficult type of atrial septal defect. This is an apical four-chamber view. Typically, in an apical four-chamber view, if you have a SVC type of defect, you don't see the defect in the superior portion of it. But here, you clearly see, because here it is typically at the entrance of the IVC, so you don't miss these IVC type of defect in the four-chamber view if you're looking for it thoroughly. And now it is considered that an IVC type of sinus venosus defect is best seen in the parasternal short axis view, where you see that the defect is more posterior, and you also notice that the PFO is intact. So that is what is the diagnosis. Of course, many of these reports that you would see would diagnose this as a post-operative atrial septal defect. Now, regarding the PAPVC, it's a difficult thing to diagnose an IVC type of defect, but these are a series of 4 pictures in the parasternal short axis view and the apical 4-chamber view, where you clearly see that the pulmonary vein, typically the right lower pulmonary vein, is actually straddling the defect.
Can you be a little more closer to the system?
Okay, you can see.
Yeah, that's perfect, sir. Perfect.
You can see that the right lower pulmonary vein is actually straddling the defect and causing a partial annulus pulmonary venous connection. But these are difficult things to diagnose, and TE generally is not very helpful in these situations. Atrioventricular septal defect, we all understand, is a more complex anatomy. We have to use a combination of views in order to assess the defect and the hemodynamics. Typically, we have a common AV valve and a separate AV valve. In the common AV valve, you can have a large AST and a large VST, whereas in a separate AV valve, typically you have a large AST and a restrictive VST. But remember that you can have the whole permutation combination with various sizes of the AST and ventricular septal defect. Of course, you have this atrioventricular valve regurgitation, LVOT obstruction, so much more thorough assessment needs to be done. Here is a combination of view. The upper panel shows that this is a partial atrioventricular septal defect. This is a sagittal view from the subxiphoid. You can see a large atrial septal defect in the so-called ostium primum position, but you see that the ventricular septal defect is absent, or it is very small. If you look at this here in the right-hand corner, you don't see a very large ventricular septal defect. Anatomically, it is large, but it has been tethered and it is physiologically closed. Here is an example of a partial atrioventricular septal defect in the bottom left side, and you see that there is a very small atrial septal defect. And you feel, there's nothing needs to be done possibly for this, but suddenly you notice that because of the cleft mitral valve, there is severe atrioventricular regurgitation. So these are things which needs to be clarified. This is a much more complex form of atrial septal defect and which needs thorough investigation. Of course, till now, we don't talk about any interventions in these type of atrial septal defect. But since I had to talk about the anatomy of the atrial septal defect, that's why I wanted to complete this. Here is an example of a complete atrioventricular septal defect, where in the sagittal view, you see a complete common atrioventricular orifice. Here, you notice it in a moving picture, and in the right-hand corner, you notice that there is a very large AST as well as a large VST. So you can have these permutation and combination with these type of atrial septal defect. I now move on to the anatomy of ventricular septal defect. There was a time when we all trained, we would always look at the ventricular septal defect from the left ventricular side. We always did a left ventricular angio. We would say that this is a subaortic VST, utilize all sort of terminologies. We would do a right ventricular angio in a LAO view, left ventricular angio in a LAO view. We would do a left ventricular angio in a REO view. That's all we had to do. But now, the way we look at the ventricular septum is completely different. We actually look at it from the right ventricular aspect of the ventricular septum instead of the left ventricular opposite, which was the traditional view when we trained. So if you look at these images, you see you are opened up the right ventricular portion or anterior wall of the right ventricle, and here you see definitive landmarks. We see the pulmonary valve, we see the tricuspid valve, the septomarginal trabeculation, and it is based on these definitive landmarks, which is not present on the left ventricular aspect, that we start defining where a ventricular septal defect is present. And this is how we define the ventricular septal defect nowadays. We have removed the right ventricular free wall. We are looking at the the right ventricular aspect of the ventricular septum in an en-fast view, and we define the various types of defects: the perimembranous defect, the inlet defects, the outlet defects, and the trabecular defect. These are the commonly used terminologies nowadays. Most of you would be familiar with this. Evaluation of ventricular septal defect forms the same schema of evaluation. We have to do the clinical evaluation, X-ray, ECG, etc. Again, echo remains the mainstay of evaluation. Transthoracic echo typically suffices in most of the patients, especially in the pediatric population. So we hardly ever use the transesophageal echo in order to evaluate a ventricular septal defect. Also, the images are never as good as the transthoracic echo in order to define the ventricular septal defect, and typically it is restricted to beyond adolescent or adults. And with this echo, we are able to define the anatomy, we get the hemodynamic information, and when we have to intervene, we also get the other bit of information like margins, the size, whether it is suitable for a device closure, or whether the patient has to go for a surgical treatment. 3D TE is becoming more and more popular in order to define it in a much better way. There have been papers, especially Dr. Shiva has written about the 3D, and actually he follows the same schema as we have following for the defining a ventricular septal defect. He looks at it from the right ventricular aspect and then makes the diagnosis. MRI, which probably will be discussed later, is more often used for complex ventricular septal defect, hardly ever used for intervention, but definitely has a role in evaluation of complex ventricular septal defect in order to look at rootability, etc., as a surgical candidate. And of course, cardiac catheterization is necessary in appropriate cases. But our initial diagnosis is always echo, and I think in the pediatric population, transthoracic echo suffices in most. So let us look at quickly the various type of these defects. Perimembranous, because these are very loosely used terms, even now if you look at the echo reports that come in, subaortic VSDs, perimembranous VSDs, they are all a potpourri of terminologies which are used, which has to be clarified, especially for the beginner in pediatric cardiology. You should make all attempts to clarify the terminologies which we use in defining these ventricular septal defects. So perimembranous VSD, which was loosely known as subaortic VSD, is basically involves a fibrous continuity between the leaflets of the tricuspid, mitral or aortic valve. This is the pathognomonic feature. The septal leaflet forms the postero-inferior margin of the defect, and multiple views are used to differentiate these features. We start with the subxiphoid as also useful, the parasternal long and short axis. And now that we have started doing device closures of many of these defects, there was a time when we were quite happy in saying that this is a large defect, this is a moderate defect, this is a small defect. But now, if you are planning intervention, we have actually got to talk about the size of the ventricular septal defect, what about the margins, etc., and finally give a report whether it is suitable for a device closure. This is a typical example of a perimembranous ventricular septal defect. You can clearly see in the left-hand corner that the postero-inferior margin is formed by the septal leaflet of the tricuspid valve. And for people who have done angiographies in the past, this view is typical of the elaeocranial view that we use. And you can see how the VSD skirts the septal leaflet of the tricuspid valve and then falls down. So if you're used to angiography, this becomes very difficult, very easy to interpret these types of ventricular septal defect. This is a parasternal short axis view, which clearly shows the leaflets of the non-coronary sinus in continuity with the tricuspid leaflet, which is actually a very important part of the diagnosis or definition of a perimembranous defect. Now, if you look at this, this is a paracoronal view of the subxiphoid view, and it shows so clearly, this yellow arrow points out to the continuity of the tricuspid valve and the aortic valve. Therefore, defining it as a perimembranous defect. This arrow here points to the fact that the outlet septum is intact, and therefore this is not a doubly committed ventricular septal defect. So these are the ways that we define perimembranous ventricular septal defect. This is a parasternal view with an inferior tilt, and you can clearly see how the tricuspid valve is very closely related with the non-coronary aortic valve leaflet with the ventricular septal defect. So that, I think, completes the definition of a perimembranous VSD. A doubly committed VSD is a very, very superior defect, which you saw in the cartoon there. And you can clearly see that now in the subxiphoid view, the pulmonary valve actually forms the roof of the defect. Also, you notice that the jet is going towards the pulmonary valve, and you don't see the tricuspid valve at all in this particular view because it is far away from this, and the jet actually points towards the pulmonary valve. It is happening now less frequently, but there was a time when many of these patients used to be diagnosed as severe valvular pulmonary stenosis. But fortunately, with the new group of pediatric cardiologists who are now actually practicing, these things are seen less frequently, unlike before when the adult cardiologists used to report these echo. Here is a subxiphoid view, which is a restrictive ventricular septal defect, which you can clearly see here that the tricuspid valve and the aortic valve are continuous with each other in this yellow arrow. And in this arrow where you see that the pulmonary valve and the aortic valve are continuous. This is a parasternal long axis view, which is the best view to define the aortomitral continuity, the aortopulmonary continuity, and you can see how very well the VSD is seen. This is very important because we don't think that this is suitable for a device closure, although I'm aware that there have been attempts to close these small ventricular septal defect with a device, but intuitively it seems very wrong because there you have the aortic valve and pulmonary valve right forming the roof of the defect, and therefore it should not be attempted. Another example of a doubly committed in the short axis view, where you clearly see how the tricuspid valve is discontinuous with the aortic valve and how the aortic valve is continuous with the pulmonary valve. We then move on to the muscular ventricular septal defects. These are very important because many of them are now attempted with device closures. You have to understand the anatomy very well. Remember that they are far away from the tricuspid valve, unlike the perimembranous ventricular septal defect, but sometimes it so-called hides the ventricular septal defect. If you look at this particular image, the tricuspid valve actually has got to be separated in order to show us the ventricular septal defect. And one has to be very careful as far as device closures are concerned in order not to damage the tricuspid valve during this procedure. So understanding the anatomy becomes extremely important. This is a so-called a muscular inlet type of ventricular septal defect, which is so closely related to the tricuspid valve. So one has to be very careful in doing an intervention. This is an inlet type of ventricular septal defect. You can see that there is an absence of offsetting here. One is the apical four-chamber view, the other is a parasternal short axis view. Clearly, one does not talk about device closures in these type of ventricular septal defect because there is no margin in the AV septal area. So the importance of defining these very clearly. This is a very anterior type of muscular ventricular septal defect. You can see it only in the superior scan when you see the right ventricular outflow tract, and you can see the ventricular septal defect. It has got margins all around, muscular margins all around. If necessary, of course, this is a very small ventricular septal defect, but if necessary, they can be attempted and a device closure can be done for these type of ventricular septal defect. This is a typical what we known as the epico-infundibular ventricular septal defect, which was initially defined when KK was working in Boston. The purpose of just to show you is that not all apical ventricular septal defect are simple. You can see that you see it only when you do an anterior scan pointing towards the right ventricular outflow tract. And of course, many of these patients are only surgical candidates. It is difficult to attempt and try to close these ventricular septal defect because these are true apical ventricular septal defect with hardly any margin towards the apex. But it is just a matter of interest that I'm showing you this defect. Most of them actually are large and they tend to go for a surgical correction. I think I'll stop my talk here and just appreciate if there are any questions or comments on.
Really, it's a really wonderful and a very lucid talk, sir. A lot of information. And you are the first person to do nomenclature of the interventional chapter. Many of the people, they don't know actually the nomenclature came from you and Savitri Srivastava madam, published a long time back actually. Still all over the world, people follow same nomenclature. And the last slide is very, very good what you mentioned, because ourselves, we attempted in 2 cases to do the device closure in apico infundibular VST. Wonderful publication by KK and Jim Locke's group from Boston. After that, one of my colleagues also, we reviewed the paper and then we understood the anatomy very clearly, which you are showing today. So I request others, Dalvi sir or whoever is available to discuss certain issues. And also Dr. KK requested me to invite Dr. Babar Hassan, Chief of Aga Khan. Is he there? Sir, are you there? Satya, can you please invite Dr. Babar Hassan?
Yes, sir. I'm unmuting him.
Can you guys hear me?
Yeah, we can hear you, but we can't see you. Can you open your video?
Yes, I can open it. Let me see if I can open that.
Yeah, I've just sent a request. Right.
Yeah, okay. My internet probably is not that good, so probably it may not open that well. So anyhow, but this was an amazing session. Really learned quite a bit. All 3 talks, and really wanted to really thank you guys to do this. One could not have imagined, sitting completely in different parts of the world and listening to this and learning so much from so much of extreme experiences. And all talks, KK's, I give his, actually, I have his talk with me and I give it to all of our junior faculty and our fellows and everybody, because everybody, as KK very rightly pointed out, it's all that excitement of putting a device in and not understanding the whole logistics behind it. But also along with that, Dr. Dalvi's talk, I think we completely underestimate the whole concept of counseling. Such humility in that talk was truly amazing. And the ASD, it was music to my ears as I kept on writing, because I kept, we always get into these, I know it's more of an intellectual academic arguments, but, only when one is meticulous about such things, of defining things and actually defining it properly, is when we understand that it shows our understanding of the defect. And that, I think, counts a huge deal when you are in the cath lab or in surgery. So thank you very much for this amazing sessions.
Thank you very much, sir, your valuable comments. Are there questions to Radha sir? Dalvi sir, would you like to ask any questions or comment of Radha sir's talk? You please unmute your microphone.
Sir, I've done that.
You have to unmute. We can't listen you. We can't hear you.
I know. I have now
unmuted. Yeah, I've done it.
Yeah, I think just wanted to emphasize what Radha said, that how imaging is at the heart of interventions. Many of us tend to think that pushing catheters and pushing devices is the way to go. But I think imaging is at the heart of successful interventions, and is also improper imaging is at the heart of complications. So unless you are satisfied with the kind of images that you have, I think going ahead with any form of intervention, may it be transcatheter or surgical, I think can produce really some disasters. And some of the images which Radha showed are, I mean, I have been seeing them for years, just terrific. Thanks for sharing your experience, Radha.
Yeah, Dr. Babar would like to ask a question. You can please go ahead.
Sorry, I missed out. While Bharat was speaking, there was some instability in the internet. Can you start your question again, if it is addressed to me?
Satya, can you ask Dr. Babar to speak? Satya, can you unmute?
Yes. Yeah. He's already unmuted. 1 minute. And there are some more questions, sir, like which I've sent you on the WhatsApp. These are like to all the speakers. So if you have time, if you can like address it. Dr. Babar is like unmuted.
Dr. Babar, can you please ask a question, or else your internet may be a little bit poor connection. You can type the question also if you're not audible. Okay, then Radha sir, did you get your questions? Yeah, I can't unmute, he said. But you can type your question, at least we'll repeat your question.
I have some questions with me here.
So I can unmute. Can I quickly go through? So just if everybody who gave a talk can give a little bit of the modification that they are doing with the whole COVID-19. So for KK, are you now using a corona or COVID test before you take a patient to the cath lab? For the imaging folks, are you now really discouraging any kind of sedation TEE because it makes the patient cough a lot, and all TEEs done under GA?
To answer that question, KK had to go some kind of urgent work, so he is not available at this point of time to answer. But I had the interaction couple of days back with the KK. They are not doing any kind of elective interventional procedures as of now. Only emergencies, he said, and they are using all precautions of personal protection equipment. Maybe you can ask personally, you can send
same here, Nagesh, we have stopped doing elective procedures for now.
Yeah, others can answer, even Bharat Dalvi sir can answer that question.
No, we have also stopped doing. As a matter of fact, for us, there are hardly any patients, and our hospital policies are very strict in this aspect, that no elective patients will be done.
Radha sir, you have some questions in your WhatsApp. Can you see and then speak? We have a couple of minutes of time.
I couldn't
We can stop after 5 minutes.
Yeah, closing trabecular VST in patients with non-obstructive RVOT muscle, can this delay the progression of the obstruction? The answer is no. I mean, it's a separate pathology. I don't think closing would help. The difference is that the VSTs tend over a period of time to get smaller, but the RVOT obstruction always almost progresses. That's what the natural history explains it. So if you feel that there is an RVOT muscle, and if the VST is not big, it can wait. I think it is better to wait and let the natural history unfold by itself over a period of time if the patient is not symptomatic. If he's symptomatic and you feel that it is because of the VST, then of course it is better to send it for surgery.
I'm actually able to come back now to the meeting, Nageswar.
So, yeah, there are some questions from Dr. Babar, but I can repeat whether his microphone is mute or unmute. I don't know.
I heard that discussion and you answered for me. That's fine. That's exactly what I would have said. Now,
yeah. Do you know his question?
Yes, regarding COVID patients, what you need to do, what precautions you need to take. He said that we've stopped elective procedures, and for emergency procedures, we wear personal protective equipment. That's exactly what we are doing. Right now, we haven't actually reached a stage where we have declared community transmission. So our current situation in Kerala is that we don't assume everybody is COVID positive yet. So we follow PPE only if there is a suspected COVID or a proven COVID case. Otherwise, we are not having to wear PPE for other cases as such. This universal COVID precaution policy will only come in when there is an official declaration of community transmission. That hasn't happened yet. So we need not, it's extremely difficult to function in PPE for anything. To do interventions is very, very difficult. So one has to be really absolutely sure if it is, firstly, the procedure is indicated, and secondly, you can, if you can actually avoid doing it for that particular period of time, that may be the most appropriate thing.
There is another question here, timing of device closures for VSR. I mean, you mean ventricular septal rupture?
Yes.
Well, it's a very controversial issue because there is something called damned if you do and damned if you don't do. Ventricular septal rupture, if you look at the recommendations of European Society of Cardiology and American Heart, they don't even talk about device closures. Today, the best option is to do a surgical closure. They have been able to bring down the mortality of surgical closures of ventricular septal rupture down up to 40%, unless it's a desperate situation. And typically, it's a question of coming back from the cath lab and saying that, oh, my procedure is successful, but the patient is not alive. Because remember that there are multiple issues in these. If you have ever gone to the operation theater and looked at a ventricular septal rupture and seen a jelly-like structure there, you always wonder how you can fix a device here. Although there have been reports of successful device closures, but the success typically occurs in patients who can tide over about 4 to 6 weeks period so that the margins are firmed up and you can easily fix a device if it is necessary. Typically, these occurs in patients who do not have very large VSTs, they have not gone into cardiogenic shock, etc. There is a second group of patients who come to you after surgical closures of ventricular septal defect because they face the same problem. The tissues give away. They come back to you with residual shunt, typically after some time, after 4 to 6 weeks. These are patients who are probably suited for device closures. I used to do ventricular septal ruptures in the beginning, but then I realized that I don't think we should do it in the immediate period. It is better to send the patient for a surgical closure.
Screen sharing so that I can show tomorrow's question.
Nageshwar, there are a few questions for me. Do you want me to take it now or shall I?
Yeah, so we have 3 more minutes time. One question each can be answered. At 1:30, we would like to wind up this session.
Okay, I have one question I'll answer quickly. That is warm saline. It's very easy. You just take the bottle of normal saline and put it in a warm water bath. And you can get it up to, you can put a thermometer if necessary, but that's also not necessary. You can get it up to a reasonably warm temperature, and then that warm bottle can be used for the babies, and it's very essential for the very tiny babies.
Thank you, Nageshwar. That was a wonderfully conducted session. And nice to see KK, Bharat, everyone, and very happy they're all very safe.
And I think, Nageshwar, we have learned something from this session. Yes, I think that you as a moderator could go through the chat box and note down important questions. So at the end of every talk, you can ask the relevant questions so that we get a little better when we come the next time.
Sure, sir. Definitely, I will take your all aspects. Today, we'll do a lot of homework. I will have a discussion with KK, Satya, and you also. And we'll definitely improve by tomorrow and this week itself.
No, it was a great experience, and I think it was a wonderful start. No question about it.
Yeah, little bit of audio visual aspects in the beginning. We'll overcome that. KK sir, in your talk there was a little bit of cross talk was there. We agree, and we'll try to solve those issues by tomorrow.
Yeah, these are teething problems, but we have done well, I think.
Okay, sir. So thank you, sir. Thank you very much, sir. Have a safe.
Thank you.
Thanks a lot, sir. Can I close the meeting, sir?
Yeah.
Yes.
Thank you.